This week on the BackTable podcast.
What can I say one thing about that?
Yeah.
You got to find some way to clamp for men, you got to find some way to clamp the penis. And because otherwise
it will go that way too. Very good point.
And urban legend has it, and I don't know if this is true, I haven't independently verified this, but my buddy Scott Delacroix takes the
shout out Scott. Yes.
takes the rubber bands off the Wall Street Journal newspapers that show up every day at his clinic, and that's what I don't know, Scott, maybe you
probably
can
dips them in
clarify.
some alcohol first. Yep.
Maybe a
Love
Cunningham
it,
clamp,
Scott.
Scott.
Cunningham
clamp
we
would
do have
probably be better.
equipment designed for this.
Can somebody introduce Scott to a Cunningham clamp?
Welcome to the BackTable podcast. I'm Bogdana Schmidt. I'm an assistant professor of Urologic Oncology at the University of Utah, and I am very excited to have with me today Dr. Mark Tyson from Mayo Clinic, Arizona, Dr. Suzanne Merrill from Colorado Urology. Everyone knows your bladder cancer bona fides, so I'd love for you to share with our audience something that they don't know about you. Mark, we'll start with you.
Okay. Well, I'm married to a marriage and family therapist, and I'm not sure that many people know that about me. She's a wonderful person. We've been celebrating 18 years this year.
Congratulations.
Yeah, thank you. And if you've ever seen the movie Saving Silverman, it's exactly like that.
I haven't seen it, but now I have a movie recommendation.
Now you have some homework to do.
That's awesome. Well, I would say something unique about myself is, in addition to lovely family, husband, and 2 kids, is my experience that I had as a child where I lived in Japan for many, many years. And this was back in the heyday. My dad worked for Kodak when there was kind of the film wars between Kodak and Fuji. And so it's been kind of a hope of my husband and I to take our family back there and to go, as we're big skiers now, to ski Japan.
That's super fun. My family and I actually went to Hokkaido last summer.
Oh,
but we went in the summer, but we want to come back for skiing as well. It was a fantastic trip.
Well, today we're going to be talking about sequencing and combining therapies for non-muscle invasive bladder cancer, focusing on the BCG-refractory space. So to start, I want to highlight for our audience why we're really having a conversation about this, because for so long we were relying on BCG when patients didn't respond to BCG, and they were offered a cystectomy, and obviously the patients who went that route had that course and had that outcome. But many of our patients were not cystectomy candidates or refused cystectomy for life reasons. And for those patients, we were really grasping at straws for a very long time. So pembrolizumab was approved in 2020, nadofaragene in 2022, and 803 in 2024. So now 2025, we have several years worth of data. Of course, before all of that, and really during COVID and before COVID, before the approvals, a lot of folks were using sequential gemcitabine docetaxel without any prospective trials in the space. So now we have therapies to discuss for these patients. Mark, can you review for us, how do you think about these FDA-approved therapies today? Are there some you're using more than others in your clinic?
Definitely. Well, you summarized it nicely, and I'd add in Thiatepa, which was FDA-approved in 1960-something, 7 or 8, something like that, when we called it superficial bladder cancer. And valrubicin too, which
that's true especially for our Canadian listeners.
Yeah, so for BCG-refractory CIS, I think is kind of the indication there. So not unresponsive. Your question about unresponsive disease, I think, really pertains to these more newer therapies. The way I think about them in terms of safety, tolerability first, like quality of life, and efficacy second, which I think is a little unusual for oncologists to think about it that way. But we're dealing with a disease state where we really don't want to make the disease or the quality of life worse, even if we make the disease a little bit better. And so I generally shy away from using pembrolizumab. Not that we don't ever use it, but when we do use it, we use it generally on trial and usually in combination with something like gemcitabine for A03, 1803. So we're not using a lot of pembrolizumab because of that safety piece. The efficacy is probably there, but 10 to 12% autoimmune mediated adverse event rate to me is just too high. So I don't generally use a lot of systemic IO therapies for non-muscle invasive bladder cancer. Occasionally for somebody who I think might have invasive, T1 disease, really high risk concomitant CIS, those are people that I generally selected for those trials to put, in combination therapy with IO therapy, because truth, thought it was just a hedge against, like metastatic disease.
Yeah, micrometastatic disease.
Potentially there's 10, 15%, very high risk. They don't want cystectomy. Okay, we can consider it in that situation. But for most garden variety CIS or high-grade TAs that's refractory to precisely 5+2 doses of BCG, I'm generally not using it. That's where I think nadofaragene firadenovec and nogapendican alpha and bacasec come in. So I generally use both of those in that situation. But yeah, I think that there's, I don't know that I'm using one or the other more. I've used nadofaragene longer just because it was FDA approved
and available
sooner.
Earlier.
But I think right now it's a pretty even split amongst those. And then maybe a distant third would be gemdosi, although that's not FDA approved, obviously.
And Suzanne, how about you? What's your split like? Similar to Mark or a little bit different in your practice?
Yeah, probably just a little bit different. I mean, I completely agree about the pembrolizumab issue, right? It's a very different administration route. Our patients are not familiar with that. A lot of us urologists might not be familiar with that. I think, thankfully, nowadays we're getting more used to maybe, administering, whether from a trial standpoint. Out in private practice, we have an infusion center. We are infusing IOs. But I think still that is, with the efficacy, different route of administration that's on the BackTable. In regards to, the two prominent out there, nadofaragene and I'll just say NAI for the other, is nadofaragene, I think, seems to be more accessible. So from a BCG supply standpoint, thankfully, we don't struggle with that right now, but I know a lot of practices do, and that really kind of inhibits going to NAI first. And then nadofaragene, I think, has the benefit of the every kind of 3-month installation. That's a really attractive feature to our patients who many times at this point in time have kind of the, hostile bladder, urgency, frequency. They're older. They don't want to travel to the clinic as frequently. They want to de-intensify their treatment. So that's probably where I'm gravitating first and foremost. And I think the patients are also, when they hear the options.
Yeah, they always say, attracted. Oh, you're saying I don't have to come in once a week? No, I want the one I don't have to do that with.
Exactly.
I agree. I think that's very important part of it. What about BCG? Are you still reinducing with BCG for some patients? Maybe, let's say, for that patient who maybe didn't get 5+2, but got 5+1, or maybe got half-strength BCG because there was a shortage going on at the time. Are you still reinducing with BCG at all for those folks or no?
I am. I think it depends on the situation. So I think what's even more important potentially is just sticking to that 8507, SWOG 8507 protocol of getting this induction done and then the maintenance at 3, 6, and then every six months thereafter. And so I think adherence to that is paramount. And so in my practice, I try to do that, but we do run into issues with sourcing BCG. So we are kind of going down to 5 of 6 and 2 of 3, which we want to be careful. We don't want to stray too far based upon the Nimbus trial results. But we are reinducing. I think if somebody's failed just 5 doses and then they have a recurrence right away, maybe not a recurrence, maybe a persistence of disease, I am reinducing at that point. And then I'll also reinduce when patients have had a long duration of response. So even if they're on maintenance, it's 3 years later and they're still on maintenance and they have a
small papillary recurrence
absolutely,
or something.
That I'll reinduce in that situation too, because I consider them really, even though they're technically BCG-unresponsive, I think of them as BCG-responsive just because they had such a long duration of response. So I am reinducing.
I think it's interesting you brought up that you try to stick to that 5+2. I do that for trial eligibility purposes, basically, so that everyone's at least gotten that so that I could potentially put patients on trial. But I think we're going to have some more experience with doing that, and maybe people are going to get more comfortable with that 5 instead of 6 because it seems to be effective enough comparatively.
Yeah, and I will say there's a lot of consternation from patients. I don't know, I'm sure you guys both see this too, and they say, well, is 5 just as good as 6? And I usually answer that with probably not. I mean, it's probably not as good. I mean, I can't.
Well, if you can get them 6, but are you saying that you're strategically stopping patients at 5?
For our practice, all patients get 5+2 for maintenance and induction, and we have to do it that way because we can't otherwise treat all the patients who would need BCG. And we just make it fair, whether you're a person of means or not, everybody gets 5+2. And then, so I get that question, is it just as good? And I genuinely don't know the answer to it, but I I kind of err on the side of probably not. But as soon as we get more BCG, and we can maybe next year when Merck's making more, or maybe when we open the expanded access program, maybe when we get more, we'll be able to go to 6+3. But right now, this is the way we have to do it to make it fair.
I mean, I think that's a really interesting point because, right, where that data came out that we started off with 6 really is not, hard and fast rooted in great evidence, right?
No, it was the 6 vials were available and 6 vials were split.
And we're good, right. So I think we need to, investigate that. I mean, in regards to challenge the old traditional way that it could be. I know it's caution for sure. So I'm glad you're doing that.
I'm a little self-conscious about it, to be honest with you, because, I think the Nimbus trial, I referenced it earlier, but I think they did like 4 instead of 6, and then the maintenance schedule is different too. It was clearly inferior. So I discuss that with patients and I say, just do it. We're doing the best that we can to meet the demand. This will keep all of your options open, like Bogdana just said, for clinical trials. And that's also part of the reason why going back to the reinduction question, it's like, I know that they only got 5+2. And so like, maybe they just need more BCG. And so I do err kind of on that side of reinduction.
And to go back a little bit to what you were talking about earlier on what you're doing in your practice for BCG-refractory patients, BCG-unresponsive patients, I should be more specific, and that we're not going to reinduce with BCG. Let's say you agree, you believe we need to move forward, patient's not a cystectomy candidate. You mentioned pembrolizumab you shy away from because of just the systemic adverse effects rate, similar in my practice as well. But between the agents that we do have available, are there specific patient factors outside of patient would prefer Q3 months as opposed to once a week, the disease-specific factors where you favor one drug over another, or is it kind of a host of things?
I would say it's a host of things. And I think it's a complicated internal algorithm that I'm going through when I have that patient in front of me who, has met that BCG-unresponsive criteria. It's, like Mark said, efficacy is out there, right? We're, all coming from a training where efficacy definitely reigns in our head, is prominent. But right, with all these trials out there, kind of single arm, there's no cross-trial comparisons, or we can only make cross-trial comparisons, which is not great to do. But that kind of falls down in the roster when you're talking to that patient. Really what is in front of you, and typically a older patient, is their current bladder symptoms, urgency, frequency, their values and goals, and what they want their treatment to be. It could be potentially like, I do want to de-intensify my treatment. I don't want to be traveling to the clinic all the time. And then, of course, you have to weigh in kind of what are you dealing with that tumor recurrence at that time? Have we escalated? Are they now showing a T1 where they were just TA high grade? And so it's putting all these things into, again, that internal dialogue you have with yourself to figure out what agent is going to be the most appropriate, I think, for them. And I tend to find that a lot of these patients at this stage, as long as their disease hasn't shown also a progression, we're still in the non-muscle invasive category, but hasn't shown a progression. It's just, again, another TA high-grade recurrence, but they meet that criteria, then again, putting cystectomy kind of down on the line of the options and using some of these new novel agents out there is going to be probably best for them.
And Mark, counter to that, so what are the things that make you put cystectomy further up on the, meaning right up on the line there? So what is it that makes you say, look, we do have these FDA-approved therapies, but here's why for you, I'm still recommending cystectomy?
For those really high-risk histologies, so anybody with variant histology, plasmacytoid, micropapillary differentiation, nested variants, all of those, that generally pushes me towards cystectomy. That's usually accompanied by invasive disease, T1 disease, concomitant CIS. Anybody who has like extravesical disease, so in the urethra.
So I was just going to ask, prostatic urethral recurrences, how do you handle that?
Yeah, prostatic urethra or upper tract too. So they may have distal ureteral tumor. All of that pushes me towards cystectomy. And the way I handle the prostatic urethral recurrences is do complete TURs to the best of our ability. And then if it is, especially if it's invasive in the prostatic urethra, if it's a high volume, I think that tends to be, more of those tend to be stage 3 on exam and on the final pathology than they are stage 1 or 2. So I tend to move in that direction for those patients as well. But for those patients that have just a little bit of 5+2, you clean it up with blue light, their bladder overall looks pretty good, they have excellent urinary and sexual function, I generally don't recommend cystectomy up front for BCG-unresponsive disease. I generally do try to do some type of bladder-sparing therapy, 1 or 2, maybe even 3 rounds of it, clinical trial, just because I don't think that the disease is life-threatening at that stage. And you have to be very careful because sometimes it's a very sneaky disease and sometimes these patients, they can get away from you easily. But I think it's a conversation you have with the patient and you just that's generally how I steer them. If I'm going to steer them towards cystectomy, that's generally how I steer them. And there was one more patient group that I'll just put out there for cystectomy. I know the two of you do as well. Your center's high volume solid organ transplant patients. These are patients that they just don't respond to anything, especially the immunotherapies. I've found that they don't really respond to the intravesical chemotherapies either. And so solid organ transplant patients, I generally am pushing towards cystectomy as well.
Yeah, I think that's fair. I think especially if those patients in particular really have so much exposure to the healthcare system, they are more than happy to not come in for things. They're much more, at least in my experience, have been much more surgery inclined rather than multiple clinic visits, multiple surveillance things. They're already dealing with so much and they don't want more.
And that brings up a good point that, when you're posing all these options to the patients, of course they hear cystectomy and right almost at that word or description of what they would have to go through, they almost kind of shut down in that's a viable option. And of course, they want to keep their bladders, et cetera. But what I think they don't appreciate, and it is hard to get them to understand this, is how much they have to do to keep their bladders and the frequency, the intensity, and et cetera, the potential worsening of bladder symptoms. So it's hard to contextualize, I think, that to ensure that they understand that. And you almost have to take them through that process for them to really understand that. But sometimes, like you said, cystectomy can be, if you can get them through that huge surgery, which is very challenging, but it can be kind of more of a easy road. And I guess to bring up the cysto trial,
I'm waiting. I'm waiting.
You're waiting to being so polite. Yeah.
But I think it's great.
Yes,
we now have data. I think or at least we have the abstract presentation. I want to see all of it. I want to see the manuscript. But you're absolutely right. We have the cysto data to show that from a cognitive perspective, from a financial well-being, from a mental health standpoint, these patients are doing better with a cystectomy than with bladder sparing. And certainly from the sexual function perspective, I think that bowel. Yeah. And bowel, right. That's the bladder sparing still has an advantage. But yeah, I think it's good to be able to present the whole thing. This is a lifelong disease for a lot of these patients. And then the non-muscle invasive spectrum is broad and patients will transition from one part of it to another. And I think it's hard for them to appreciate in one appointment just what bladder sparing looks like. So we're going to focus on bladder sparing, though, and talk a little bit more about the intravesical therapies that we have. So we'll start talking a little bit about nadofaragene. So we discussed that it's now been approved, available for a few years. We all have some experience with it. Suzanne, could you talk us through a little bit about the mechanism of nadofaragene and the key trial data, just to recap that for our audience and what your experience has been with it in practice?
Of course. So nadofaragene really is one of the first gene therapies approved by the FDA in bladder cancer. And what it is, it's a modified adenovirus, which serves as a vector and allowing kind of a infection into the bladder cancer cells and the interferon alpha 2b gene to be incorporated and ultimately produced by these cells in a sustained manner. And I think what's important for everybody to know when we talk about a gene therapy, people get a little bit hesitant of using it. And importantly, it does not incorporate itself into the host genome. So I think that's very important. And then it doesn't generate like a widespread infection either. Okay. And so with this kind of sustained release of interferon alpha 2b, ultimately that just stimulates the body's immune system to activate, natural killer cells, cytotoxic T cells, and really allows and causes these bladder cancer cells to undergo programmed cell death. And it also inhibits kind of blood vessel growth, again, further preventing these tumors from growing. So in regards to the key trial data, this trial, which led to the FDA approval in 2022, was a single-arm, multi-center phase 3 trial. And in the CIS cohort, with or without papillary disease, we saw with giving nadofaragene, again, every kind of 3 months, that the 3-month CR rate was 53%. And about half those patients, 46%, actually sustained a complete response at 12 months, which made a 12-month CR of 23%. Now, they also, of course, looked at papillary-only disease, and what happened with giving nadofaragene there. And what you saw was actually even a little bit better response. So at 3 months, the recurrence-free survival for high-grade disease was 73%. And 60% of those patients sustained a response, to 1 year. And I think what's interesting is that, yes, FDA approved in CIS with and without papillary disease, but the NCCN recognizes those positive results in papillary-only disease and gives it a 2B recommendation. Fantastic data and really remarkable, and really set the stage after, pembrolizumab in 2020, that we can make a difference in BCG-unresponsive disease with this drug. So in regards to kind of that question of how, again, these novel drugs are expensive, we want to make sure that these patients receive these drugs for the full amount of dwell time, because it's, of course, an intravesical agent. So what can we do to make sure that these patients keep this drug in place? What I do is, of course, first, try to understand what's going on with the patient, and that, is this a patient with baseline urgency frequency, or are they already on an anticholinergic, beta-3, et cetera? And I typically, if they're not already on something, I actually institute something beforehand for them. Maybe, again, if they don't have many symptoms, I give them that drug, that morning of, leading into it, which can help.
So just that day, you don't start it a week earlier or anything?
Yeah, good question. It really depends on what's going on with them. So if really they don't have a problem at all, then I would give it to them actually kind of that morning, a short acting like oxybutynin, for example, and many times like an oxybutynin extended release that morning. But if they do have a lot of symptoms, we're instituting that beforehand, seeing how they're doing, maybe changing up the drugs, et cetera. I'm a big proponent of Valium.
I was going to ask Mark about that in a second.
Yeah, but I think it also helps Valium on 2 levels, right? It can, of course, help at the level of the bladder, but for some of these patients who are very anxious, just in general.
So are you giving oral Valium to these patients?
I am.
Okay.
Yes. So I think that can be an option, because I know, Mark, I'll let you go ahead and talk about another route of administration. But Valium, I think we forget about that drug.
Yeah.
So.
Yeah, I agree. No, the strategies sound very similar to our strategies, and I'm sure pretty similar to Bogdana's as well. We have been using rectal Valium, so rectal diazepam, and it's compounded from the pharmacy, so you need a good pharmacy partner to help you with this. It comes as a gel. We give it 15 minutes right before, obviously ensuring they have a driver home, because get
the systemic,
pretty loopy.
Right?
You're right. Yeah, because
they get loopy off the rectal Valium.
Yeah, a little bit. Yeah,
all right.
not. I mean, I think it.
It is a gel, so I'm sure it's
quite I'm sure there's some. Yeah.
So to your point about the supratentorial benefits, right? So I think there's some benefit there that's real, that relaxes them, and that may be explaining why we're seeing less loss of the medication. But we described that experience in about 40 or so Ferring patients that we treated across the 3 Mayo Clinic sites. And our loss of medication went from like 25 to 30% down to like 5%. So it was pretty good. And then our bladder spasm rate went from like 50 to 60% down to about 30%. So it does not eliminate the loss of the medication, but it greatly improves its tolerability. And then when patients are still losing the medication, they're still having painful bladder spasms, we'll add in those oral medications you mentioned earlier. I generally have been using like Calmette-Guérin or something like that. But we actually try to treat them kind of like a few weeks in advance to try to get this, maybe even a couple months. Or if we know they're going to be on it, our APP will just start it now, start it when they see them in the clinic and say, okay, we're going to start installations in a few weeks. You're just going to stay on this for the next couple of months.
And with those beta 3s, you do need to start them well in advance. They cannot be given really, or they're not meant to be given day of. So
yeah, absolutely. Yeah. I've changed my protocols a little bit based on our conversations about rectal Valium. I've actually not been able to get it done with my pharmacy partners. They have to get it compounded. The patient has to bring it in from a separate pharmacy. So logistically, we haven't worked that out yet, though I'm working on it. But we did get B&O suppositories back. And so check with your pharmacies. I think they're available now because I now have them at the VA and I now have them in my cancer center. So I'm actually thinking about trying that because at least we have that available and seeing how that goes while we're working on the rectal Valium. But similarly, I do oxybutynin and beta 3, I start them if the patient has some baseline.
Old trusty, the B&O suppository.
Yes.
I mean, that may work better. I'd be interested. Let's
look. Let me see 40 patients and we'll compare data.
I will say though that we've had a couple patients just lose the medication like right away. So just
installation,
$60,000 that just comes around the catheter. And Ferring, I don't know if they want me to say this or not, advertise this or not, but they were pretty good about just replacing the doses.
No, that's actually
wonderful.
part of their their policy.
Yeah.
I think that it's on their website and it is something that they work with university partners about that.
I just email the rep and say, hey, we need
happened.
We're not buying another dose, but can you give us another?
Yeah.
And they're generally pretty good about it.
One thing I'll bring up, which is kind of an interesting little tip and trick. To tell you the truth, I personally have not used this trick, but I've heard about it. And from what I heard, it works well, is that obviously you have to know if the patient's going to have these bladder spasms. We all know that one trick is you can leave the catheter in, you can clamp the catheter, but they can spasm around it, right? Well, one option to try is having catheter in, patient's recumbent, don't clamp the catheter. Actually, yes.
Gravity.
Right. Pull it up to an IV pole and supposedly, that bladder spasm will just kind of have that urine go up as a column and then back down. Fascinating. Again, haven't tried it, but people that have said, yeah, give it a whirl. So I don't know, just another little tool in the toolbox.
Well, and that's what this is all about, right? This is figuring out what you've seen and heard of and trying to share that knowledge with our whole community.
You got. Well, can I say one thing about that? You got to find some way to clamp for men. You got to find some way to clamp the penis. And because otherwise
it will go that way too. Very good point.
And urban legend has it, and I don't know if this is true. I haven't independently verified this, but my buddy Scott Delacroix takes the
shout out Scott. Yes,
takes the rubber bands off the Wall Street Journal newspapers that show up every day at his clinic, and that's what he. I don't know, Scott. Maybe you
probably
can clarify.
Probably dips in some alcohol first.
Maybe a Cunningham clamp, Scott.
Cunningham clamp would probably be better. Designed for this.
Can somebody introduce Scott to a Cunningham clamp?
So we were talking about data as far as the initial trials. We're talking about administration. We now have some 5-year data that Dr. Narayan published. I know you just published 1-year data across all 3 Mayo sites, looking at outcomes a little bit past the initial trial, past a year. Can you talk through that a little bit?
Sure. Yeah. Vikram's 5-year data, I think, is obviously far more meaningful. It's from the trial. It's from the trial itself. We published retrospective data and we had 1-year landmark data, and we haven't published it yet. It's undergoing revisions, but I can say that our experience was very similar to the trial experience, and that was nice to see in a real-world study. We saw the drug work. I think the complete response rate anytime, and remember this is a BCG-Unresponsive only population. We did treat papillary only patients, so a little indication creep there in our practice, but no BCG exposed, no BCG naive, certainly no BCG naive. It's all BCG unresponsive people. 75% complete response rate at 3 months. We were reinducing, which I know
we're going to talk about next.
Special academic interest in, but we had a pretty good complete, and that was durable. I think our around a year it was around 40% in all comers, but it's real world data, so it's not especially informative other than in our own practice and our own patients, we saw the drug have the activity that we expected it to have. But there are some wonky things about the data, like the papillary-only patients did a little bit worse than the CIS patients, which was reverse of what we saw in the trial. So, but safety was there. I think we had like an 8 or 9% grade 3 rate. None of those were, significant, like fatigue or something. And then no grade 4 and grade 5. So safe and I think effective. So we were pleased.
Yeah, I think real world data is important because it allows us to trust the trial data more, if anything, right? So you're a part of this work and you've already alluded to it, so I'm going to pick on you a little bit longer. But speaking of real world data, we just pooled basically everyone's relatively short experience across 8 sites looking at patients who underwent reinduction with nadofaragene. So if they did not demonstrate a complete response at 3 months, or if they did demonstrate one at 3 months, but then had a non-progressive recurrence, so like recurred with a TA but didn't become T1 or something like that, we saw that up to 47% of patients achieved a response at their next assessment with the reinduction. And obviously, we know that in the initial trial data for nadofaragene, they didn't reinduce their patient. So the patient didn't have a response at 3 months. That patient wasn't offered a reinduction dose. So you've been doing it. I've been doing it. A handful of our friends and colleagues have been doing it. And we saw this data. How do you explain that? How do you think that compares to an 803 NAI reinduction data or BCG reinduction data, which, of course, we talk about, we still reinduce with BCG today?
Yeah, this was obviously thanks to your leadership. This was your paper. I was happy to be a part of it. My experience wasn't as good as the average experience in the paper. So I reinduced 3 and I had 1 complete response. I don't know, are we supposed to call it reinduction too, by the way? Is it repeat dosing?
I know, right? Especially with the nadofaragene,
I don't know what to call it.
Yeah,
but yeah,
because it's a single dose, so it's hard to call it a sequence.
Keeping common terminology because we're all familiar with it, right?
We all understand that framework. So I didn't have quite as good of experience as we had as a group. I actually had a 4th person. This is interesting. I didn't submit this because they were treated by, it was a medication error, not error, but like you order 4 of these at a time. And they got reinduced, they had a recurrence, and then we were going to take them off of nadofaragene.
But then they ended up getting it anyway.
Yeah, and the guy really wanted one, so he didn't say anything to anybody, so he wanted the third dose, and he got it. And so that's the other tricky thing is practices are like implementing this is just a word to the wise. You got to be careful because you put in 4 orders at a time, and they will stay on that. So you got to remember your resident or whoever's got to remember you got to cancel that dose when you don't want them anymore. And he didn't respond. So I actually had 1 out of 4 respond. But I'm encouraged by it, and I never really know what to make. Is it the TURBT? Is it the drug? And I'm sure there's a component of both. But it's like I said, I think it's like you said, 47% of them did have a response. So there probably is some activity there.
So that data, it's short and it's small, right? It's a relatively small number of patients. It's 17 patients. And the follow-up, I think, for that is really short. And so that's why I'm trying to see how that's going to factor into how we compare to that 5-year data or even going out to a year data. So I'm hoping that we can continue to look at what this looks like at a year out at least, or at 5 years out. But I think it's encouraging, back to Suzanne's point, that for a lot of these patients, it's given us the confidence to delay cystectomy, because we look at the cystectomy-free survival out of the trials and out of the 5-year data, and those patients are able to delay surgery, and the metastatic rate, the progression rate, it gives us confidence to counsel the patients appropriately for these therapies.
Yeah, right, because almost half of patients, both cohorts, 49%. Cystectomy-free at 5 years.
And doesn't it just make sense that if you give more of it, it will...
It's just hard to just give 1.
We're beholden to this like once every 90 days.
Yeah.
And that's convenient, and I love that for patients. But would we see, and I'm asking this because I genuinely don't know, would we have better efficacy if we gave more of it?
Yeah, I think to me, just out of a very simplistic kind of viewpoint, how can you call it quits just after 1?
I think personally I'm more on the side of I'd like to give less of everything to everyone, in the sense that I like that we can spread it out a little bit. But I agree with you. I think that especially, at least for me, what I've taken away from this is it's once every 3 months. Most patients want that. They'll not tell them that you said to stop, right? They'll say, well, let's just try it. Maybe it'll work again, because compared to what they're facing down the line potentially, this is an attractive enough option. And it seems to be safe. I think that's mainly my main point is I think within that reinduction period, we didn't see any disease progression. We didn't see any survival differences or anything like that. So I think it seems to be a safe strategy. So going to what you were saying about what we don't know, because this is really what we're going to be talking about going forward, is things we don't have good data about, and how do we make these decisions without good data. So let's say you have a patient who started on BCG for high-risk disease, but because of the shortage, maybe never got through all the maintenance. So they got the 5+2, they meet the definition, but stopped with their maintenance therapies at 2 years instead of 3, for example. And that patient comes in with a recurrence now. So now they meet the definition, they have a CIS recurrence. What's your next step with that patient in the clinic? Suzanne, what do you think?
Yeah, I think this is a good point to, again, reemphasize, Mark already brought it up, that when these patients have a high grade recurrence, so they're high risk, again, are they meeting this definition or not, or you're worried about them, you have to reassess them, making sure, right, they've had upper tract imaging. Are you looking at these sanctuary sites? Do you have the availability to use enhanced cystoscopy? Is this a patient that you should be using that if you do have that available? That you're just making sure when they've recurred in a high-risk setting, we're not talking about recurring with TA low grade, that we're not missing a progression event, right? And I think that's just really important to really hone in on, and that we have, again, and we're going to have more and more of these drugs coming down the pipeline, a lot of things to gravitate to. We need to put the brakes on, making sure this patient in front of us hasn't progressed, that we really shouldn't be pushing forward, that salvage therapy option of a cystectomy at that time. But to go back to this patient who's not meeting this definition of true BCG unresponsiveness, has a high risk recurrence, CIS. I think at that point, I'm thinking about gemcitabine, to tell you the truth, because they're not meeting the criteria for these new FDA-approved therapies. We shouldn't be using them if, again, they're not meeting this criteria. They're expensive. It's a lot of impact of our healthcare system, et cetera. Or you're looking to a clinical trial. That they're meeting BCG exposed, maybe. I mean, that's a difficult definition, and different trials have different definitions of that. But if you have clinical trials with BCG exposed, that could be something for them.
Mark, what if a patient came to you after getting gemcitabine as opposed to BCG as an induction? So a naive patient got gemcitabine, maybe BCG shortage scenario. Now they've recurred with CIS or maybe a high volume papillary. High-risk patient. Do you always give them gold standard BCG in that scenario?
Yes. I usually try to. I'm not familiar. I know Bridge is allowing reinduction with gemcitabine. So I would have that conversation with the patient and say, okay, you failed gemcitabine, you failed at one time and you're BCG naive. There's a trial that's allowing reinduction. It's reasonable if you want to do that too. But I always tell the patient, I say, we can always go back to gemcitabine anytime, really, if you want to. I think now is the time to go to BCG, standard of care. We've got some 5+2. And then if we recur, then you're in position to have more options in terms of clinical trials or second generation therapies. And so, going to Suzanne's point, I love that point. It was, I think, to the best that we can, if we can expand the treatments for these patients, we should. And that generally for me means transitioning to BCG. And if I may, just go back, I like what you said about the BCG exposed patients. It's exactly what I do. These are patients I'm looking for clinical trials for. And a really good one right now was Core 8 just closed, Gem-Credo. Legend has a BCG exposed arm 2.
I don't know that they're recruiting to that anymore.
Not yet. I think it's opening. It's going to open, I think, next year. And then Eugene's trial, the GAIN trial, A03, 2303, I think, is a really good concept. So you're short on BCG and you want to give more BCG. Their phase 2 data looked excellent, like 90+% complete response rate. Yeah, with Gem plus BCG in the exposed population. So that's a patient, your CIS patient that you just mentioned about failing 5+2 outside of the interval for BCG-unresponsive definition. That's somebody I would refer to GAIN. And we're opening that and we're excited about it.
Yeah, I think it really is interesting how many more options we're having for our patients, and how do you navigate that, treating eligibility window, basically trying to create that for the patient. So not trying to close them off to potential opportunities. What do you give them up front to make sure that they're open to other things? So I agree, I think, with everything that's been approved and everyone's sticking to the 5+2. I feel like we owe it to our patients to try and give them that BCG to allow them to enroll in other things. And now having the flexibility for BCG exposed is going to be really important.
It's great that trials really saw that as a need, to explore. Because I will tell you, on the community where BCG, again, can not be given so stringently, we had a really difficult time trying to figure out what to do with these patients. And that, again, having these options in these trials for BCG exposed was like a breath of fresh air, to tell you the truth. There's still very much criteria you have to follow to even meet that definition many times. But it's just nice that that's being explored.
So you mentioned the GAIN trial, which I think is a really interesting mechanism, right? It's basically I kind of think of it as like the kitchen sink. We don't know why this one works. We don't know why this one works, but they both seem to work. Let's put them together, see how that works. But from a mechanism standpoint, right, we really haven't been, at least for me, I'm not sure that mechanism factors into how I sequence things. It's more, this is what you got, this is what I have next, this is what I want to try. Do you think that we'll learn more about how mechanism plays into how we should be sequencing it? Do you think that's within reach, within the next 5 years, let's say, we're going to be using molecular testing or using pathologic classifiers or something to tell us, well, this patient should have this one first and then save that one maybe. Maybe they won't respond as well, or maybe if they progress, do that. What do you think about?
I really hope so. I'm optimistic. And this is where we need like the Josh Meeks and the Roger Lees of the world that are really like super smart translational scientists to help us design the experiments to know these answers. And, and I think we have some insight now, and there's some pathology classifiers like the VESTA thing that just was presented at AUAs. Yeah, and so in the biomarker selected population, Gemdosi did better than BCG, which I think might be the only time I've seen anything do better than BCG, by the way. And, and I think in some of the Credo data, like the RB enriched populations, in their phase 1, it was, they had a really high response rate in that subset. And so I do think that there's probably something on the horizon, but right now I'm not really able to use a whole lot and to point patients in one direction or the other. So I am having very broad conversations about the data at a high level and letting the patients pick.
Do you think though, and thinking about this, the biomarker thing, I think that ultimately we'll probably have a couple of, eventually in the future, couple of biomarkers, okay, that are either going to tell us, at new diagnosis, you should go to X, and then maybe, or don't go to Y, or down the line when they become BCG unresponsive. But I'm not so sure we're anywhere close to getting to where, we have drug X and biomarker to tell you if you're going to work, and then drug Y, different biomarker. So there's still going to need to be, again, that internal, algorithm that you had, that strategy of, looking at the patient, looking at the tumor characteristics, looking at, again, ease of administration, access, what is your BCG supply, all those things that are going to just have to really kind of come into play, that they'll help us somewhat, but I don't think it's going to be, so, again, biomarker driven at each standpoint. I think that's important, that probably we're not going to, reach that anytime soon.
I hope you're wrong.
I know. I hear you. It would be so much simpler that, okay, you got this test and you go.
I don't know.
Maybe we don't need a biomarker-driven approach, certainly the most sensible, but there are trial approaches to this too. So soon, we're going to have all of these drugs that are FDA approved, and does lend itself to a large trial where patients are crossing over to different therapies.
Sequenced, yep. Mm-hmm.
And it's a little more agnostic to the TM component, but it probably would give us some insight into how to sequence these therapies. And that might need to be done through the NCTN, like a cooperative group.
Sure. I mean, I think that we are, again, pulling these sequences completely out of thin air, right, without any respect for the mechanism. And I'm certain that there is some priming that happens with one for another. And I hope we figure that out. And I agree with you. I think the only way we're going to figure it out is by looking at who got what in what order and having the tumor response characteristics to evaluate. But you mentioned, obviously, these big trials. So how do you make those decisions for your patients, or how do you balance, rather, that desire to enroll patients in a trial for something new, something you're excited about, versus giving a patient something that's already FDA approved in that space, that has a published track record, where you can say, I don't know exactly what your experience is going to be, but this is the published experience. This is what we can expect, at least having that minimum benchmark. How do you counsel patients about that?
Yeah, sometimes it's very difficult, actually.
It is. That's why we're asking you. Exactly, for everybody.
I appreciate that. It's a really tough, because, now we have the drugs. Now, nadofaragene and nogapendican, and patients are coming in asking for that by name soon. We'll have TAR-200 and hopefully Credo and detalimogene to follow shortly after that. So we're going to be in a situation where we have kind of a lot of different options to choose from. We're in that now, really. I mentioned earlier about Pembro, but I do talk to the patients about the two FDA-approved options. But then I think still favor trials at the end of the day, because I can always go back to nadofaragene in some of these patients. And I know we're not necessarily supposed to think of this disease as multiple lines of therapy, but I still do. I still think of it that way. Patients still think of it that way, and especially those who don't want cystectomy. And so I have the conversation with the patient about the trial. That suits people who want to save their bladder really well. You know who else it suits? It suits the people that are coming in looking for alternative therapies. The herbalists who say, give me something other than whatever it is that the FDA has approved. And I say, okay, well, I have a couple of those options for you. It suits people, and that's how I portray it. I try to read the room for the patient. Where is this person headed? Are they really? I had a guy yesterday who was really unsure about. And I said, we should do cystectomy. This end of the line for you. Your bladder's not functioning well. Let's do cystectomy. And I read the room, and that guy, and he's like, that's really what I wanted. And then I try to, once I kind of sense where they're going, then I try to narrow it down to one or two options for them and then let them pick.
I think that last point is important, because soon there's going to be so many on the table that it is going to be overwhelming to not only for us providers to, hash out each one of those, that you do have to kind of take that patient in whole and then contextualize the conversation for them in a couple of options.
I think it's super challenging. I mean, I don't think we have data to drive that decision really, or between sequencing. And I think that the patient factors are going to play a huge role in this. I like you, I always encourage trial participation as well, but I have a lot of patients who come from far away and who clinical trials are not feasible. They don't want to come for extra visits. They don't want to do that. So it becomes a very patient-centered conversation. And of course, there are patients who aren't well represented in some of the trial data that we have. So we know T1 CIS, they're not a large number of patients, even across all the approved therapies. It's a very small number of patients in that particular category. So how do you extrapolate trial data for an approved therapy to situations where the patient may not be the general representative patient from that trial? Do you mention that, or do you, since it's an approved therapy, you just go with that?
Yeah, that's a very good question. I think if the CIS T1 patients, right, they're not a large portion of our high-risk patients, yes, but that's the only data we have. And so I tend to use it and don't parse it out, but on the same token, for those really high-risk patients, I really try to emphasize and get across to them, how serious their disease is. I think when they hear if it is the first time that, they don't have muscle invasive disease and they have the non-muscle invasive, they hear, I'd still use the term, it's superficial when I'm showing them the diagram, the pictures, etc. I mean, it's almost, again, a light switch, it kind of turns off. Okay, I'm safe. And so again, to your point about Valor Labs, right? They have that computational AI helping with risk stratification, individualizing it for the patients. I think this is a great opportunity. lay it out for them, in big, bold, this is your risk of recurrence. This is your risk of progression. Just another adjunct to help with that conversation of how serious their disease is.
I always think back to Ashish Kamat's paper that showed that what T1 bladder cancer is equivalent of as Gleason 5+5 prostate cancer. I feel like we don't think of them the same way. Like, oh, this is non-muscle invasive bladder cancer, but this is a really serious disease that requires care and management and thoughtful decision-making for sure. So I agree. I think that's super important. Mark, you mentioned obviously some trials already. We've talked about a few, but of the trials currently in progress or things on the horizon, what are you the most excited about? We talked about things that are going to be approved likely in the future. What do you think? Any game changers?
Well, I'm biased, heavily biased here. I used a lot of Cretist imaging on Bond 3, both cohort C and cohort P. I think that's another, Ad5 like Ferring, which is well tolerated and effective. And I think those two drugs are going to be a big part of my future for treatment of this disease. Very excited about TAR-200. Sunrise 1 was very promising. That paper was just published in JCO week before. Very good results. I have a lot of experience with that on Sunrise 3 as well. And then detalimogene is, I think, going to probably file in 2026. And I think that their cohort 1 is closed to accrual. So we should be seeing some BCG-Unresponsive CIS data, I think, over the next couple of meetings. And then after that would be TARA-002. I don't have quite as much experience with that. I've treated 5 or 6, but I am kind of ramping Advance 2 up, and I've found it to be pretty well tolerated and so far pretty effective. And then I know I can't remember the name, but there's like a gel, an Israeli company has a gel gemdosi product. Wow. I can't remember the name, but that's I saw that at the AUA. I saw some preliminary data for that. And, I'd kind of be interested in learning more about that.
Yeah, because that's sort of your TAR-200 concept of longer dwell time, right? But with the combination therapy.
Yeah, which I will just say, if I may, I haven't had the greatest experience with gemdosi. I'd be interested in hearing your guys' experience. Not that it's a bad experience. It's just I went back and I looked at it. I looked at our Mayo data, and I was asking Vig about this last night. I think I've treated like really difficult patients with it, like transplant patients who are on like all immunosuppression and all this stuff. Our median DOR was not very good, and we're in the process of publishing that as well. And actually, we didn't find it to be any better than single agent gemcitabine. There's a lot of selection there, but it's an instrumental variable analysis where we use like year as an instrument, and it's pretty good. I thought it was a pretty good model, so we'll see. But I don't know. I'm interested to see. So the reason I bring that is because that gemdosi longer duration might actually make it better. So I'll be interested in seeing that product too.
I haven't officially reviewed my data, so maybe I'll go back and do that. But I have a pretty good experience with it. I would say tolerability-wise, it's quite good. My feeling is also cystoscopic evaluation's a little easier in some ways than some of the immunotherapies. I think the bladder just looks a little bit cleaner. I think you get less of that. Is this treatment healing? Is this a recurrence? Like I find that a little bit easier. Most of my patients who have had both BCG and gemdosi have all said that they tolerated the gemdosi, like almost to a T. Every single patient said that the gemdosi was easier to tolerate than the BCG. But I also think that's because the patients already knew what they were into, so it wasn't that shock of this is what my bladder is going to feel. But I feel like my experience has been pretty in line with Vig's real world experience. So I don't know. We'll see. Suzanne, what about you?
Very similar thoughts to what you just said is that my patients seem to tolerate it just fine. Again, bladder's easy to surveil. And again, tougher patient population that I've used it in, but probably out in the community, less tough than what you're seeing. So I've been able to salvage bladders with that combination.
I think it's selection at the end of the day, and it's gonna, when Steinberg applied the BCG-Unresponsive definition to the 2020 paper retrospectively to cohorts from 2015, 2016, that's probably not the same group of people that come and see me in 2021 and I say, okay, you failed Pembro, you failed this, you failed that, and you're immunosuppressed, and we have this drug that's supposed to work really well, let's try it, and it's just probably a different population. But I think it needs prospective validation. That's my point, is like we've been putting gemdosi on this pedestal that it doesn't deserve. We've done prospective, highly funded, high quality phase 3 clinical trials where the data is reviewed by the FDA. And we put gemdosi on that same pedestal. And I think we need to, as a group, as a community of urologic oncologists, we need to get better data for gemdosi. Because I agree with you, it's well tolerated, it probably works great, but we need to prove that.
I agree. And I think we're going to get a lot of that from Bridge, right? At least in the naive setting. But for this, we don't have the same level of data. And I make a point to discuss that with my patients and say, well, this is what we see, but this doesn't have the same quality of data behind it. And it is something that we have to use with caution. I agree with you completely. I hate having to wrap up this conversation, but in our last few minutes, I do want you to just kind of think abstractly and tell me of agents that we're aware of, whether approved or in the process. Mark, I'll let you think for another second because you already gave me part of your answer. Are there certain combinations or mechanisms or administration schedules that you're interested in seeing for your patients? What do you think is missing? What do you think you want to see that maybe isn't in the pipeline today or isn't about to be in the pipeline?
I'm probably going to piggyback off some stuff that is just slightly getting into the pipeline, which I just think is just cool technology. Because I do think it is, right? We've been dealing with aqueous solutions, right? Just contact time. We need a better mechanism. And so Aura Biosciences, right, is coming out or has this virus-like drug conjugate, which they inject into the tumor and then use kind of infrared light to actually activate the mechanism. And again, immune mediated response. But I think using something that's targeted, right? A targeted mechanism like that. And then I do think you need on top of that to add something for, again, this kind of, right, the field effect that happens, not just at the tumor itself that grossly you can see. And so I really love enGene's product, their baseline platform, this DDX, where, again, this thing can transfer cargo into the cell. And so to manipulate that some more, I mean, detalimogene, I think, great product, soon to be seen what it's going to do for our patients, but they have a really interesting platform that I think they can monopolize on even further with what they can put in as cargo into their platform. So using something like that, that's a non-viral, again, vector to get in there and deliver maybe something like a ICI, immune checkpoint inhibitor kind of mechanism would be super cool. And then eliminating the systemic
side effects from systemic administration.
Yes, right.
For me, it's ABL22 and CORE8. So with ABL22, they're combining natafaragine with gemdosi and pembrolizumab. I'm less excited about the combination with pembrolizumab, though still interested in seeing that data. It's a randomized phase 2. And so I think from that, we'll learn a couple of things, whether combination of natafaragine plus gemdosi is better than natafaragine alone. We'll also get some average treatment effects from gemdosi in that setting. And then CORE8, GemCredo cohort CX. You know, I was talking to a PhD immunologist recently who works at Mayo, and I don't know if it's something he's seen in his lab or something they published in the past, what gemcitabine's effects on regulatory T cells, suppression of regulatory T cells. And I think in combination with an immunotherapy, that could be very meaningful. And so
getting back to mechanisms of how do we actually...
Yeah, so I'm excited about that too. So we'll see how those cohorts read out, but I think there's a lot. I mean, I could talk even more about this, but I know we're running out of time. I think that it's a very exciting time for the three of us to be in the positions that we're in, being able to help patients do the science and just see what comes of it.
It's exciting.
I agree. I think this is one of the best times to be able to be a bladder cancer person, certainly for what we can offer our patients today, and also knowing that if we can keep them alive with their disease, something new is going to happen soon and soon enough that they could benefit from it. I find that really exciting. This has been such a wonderful conversation. Thank you both so much for a great discussion. Thank you for listening to BackTable.
Thank you.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTableEuro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening and see you next week.